Imagine having a highly localized skin condition where the only way to soothe its absolute most agonizing symptom is to physically destroy the evidence that you even have the disease.
Right.
Welcome to this custom-tailored deep dive designed specifically for you. Today, our mission is to zoom in on a profound biological paradox. Based on your sources, we are going to explore exactly how a history of chronic rubbing or, scratching fundamentally alters the physical appearance of lichen sclerosus tissue.
It really is a fascinating paradox to unpack for you today because lichen sclerosus starts out with a very specific, almost delicate clinical presentation.
Yeah.
But because of its most maddening symptom, the patient is driven to a mechanical action, relentless scratching that essentially camouflages the original disease.
Wow.
Yeah, the scratching completely remodels the tissue architecture, hiding the initial diagnostic clues and creating, well, a massive challenge for clinicians.
So we are basically talking about a condition that forces the patient to inadvertently paint over the very canvas a doctor needs to see. But, before we get into that dramatic metamorphosis, we have to establish the baseline, right? We need to look at what undisturbed lichen sclerosus, or LS, looks and feels like structurally before the scratching even begins.
Definitely. To understand the extent of the remodeling, you have to understand the starting material.
Right.
According to the clinical texts in your sources, lichen sclerosus is a chronic inflammatory skin condition, and it's widely recognized by the medical community as an autoimmune disorder.
And it's mostly localized, right?
Yeah, while it can appear extragenitally, it overwhelmingly targets the anogenital regions.
Okay.
So the vulva, perineum, perianal skin, and in men, the foreskin and glands of the penis.
And when you actually look at the undisturbed tissue, the presentation is visually striking. The texts describe these distinct porcelain white or ivory spots that eventually coalesce into larger, stark white plaques.
Right, the color is very distinct.
But it's the structural change that is so wild to me. The skin becomes highly atrophic.
And that atrophy is severe. We aren't just talking about like a slight thinning of the epidermis here.
Oh, really?
Yeah, the underlying structural integrity of the skin, the very architecture that gives healthy tissue its resilience and elasticity, is being systematically dismantled by this localized autoimmune inflammation.
Okay, let's unpack this for a second, because when we look at the clinical descriptions in your sources, they consistently compare this atrophic, undisturbed skin to things like cigarette paper or wax paper or cellophane.
It's a very apt comparison.
It's crinkled, shiny, and lacks all normal plumpness.
Yeah.
So if the tissue is literally as thin and fragile as wet tissue paper, my question is, why would a patient ever subject it to friction?
Right.
It just seems like scratching would be the ultimate self-sabotage.
It absolutely is self-sabotage, biologically speaking, but, well, the patient doesn't really have a choice.
How so?
And that brings us to the hallmark symptom of anogenital lichen sclerosus, which is intense, unrelenting pruritus.
This extreme itching.
Exactly, but we have to separate this from the concept of a normal itch, like, a mosquito bite or dry winter skin.
Okay.
The sources emphasize that this pruritus is severe enough to cause major social incapacitation. It routinely wakes patients up from a dead sleep.
Oh, yeah.
It is an all-consuming nerve-level sensation that demands a mechanical response. You just have to scratch it.
So you are basically trapped. You have this deep, agonizing neurological signal demanding that you scratch, but your only canvas for that relief is tissue that is ready to tear at the slightest provocation.
Precisely. The friction is unavoidable because the human drive to relieve that level of pruritus is overpowering.
Right.
But the moment the patient drags their fingernails across that cellophane-thin tissue, it kicks off a devastating biological chain reaction.
And here's where it gets really interesting, I think, because the friction is not just a mechanical stressor.
No, it's not.
It's not just wearing down the skin like sandpaper on wood. It acts as a biological catalyst. When that mechanical friction hits the fragile tissue, it triggers the Koebner phenomenon.
And the Koebner phenomenon is critical for understanding the progression here.
Right.
It describes a process where physical trauma to the skin actually induces the formation of brand new disease lesions directly at the site of the injury.
I want to challenge the logic of that for a second, though.
Sure.
If lichen sclerosus is fundamentally an autoimmune issue, meaning the body's immune system is mistakenly attacking its own tissue, why does external physical trauma dictate where the disease goes?
That's a great point.
How does a scratch recruit an autoimmune response?
This raises an important question, and it gets to the heart of how hypervigilant the immune system is in these specific patients.
Okay.
In an autoimmune state, the immune system is already primed and, frankly, aggressive. When you introduce mechanical trauma like a fingernail gouging the skin, or even chronic friction from tight clothing or, say, a bicycle saddle, you are causing micro damage to the tissue.
And the body notices that.
Right. The body detects that damage and sends inflammatory cells to the site to heal it. But because the patient's immune response is faulty, those recruited cells end up attacking the tissue instead.
Wow.
Yeah, they lay down fresh lichen sclerosus right there.
So the friction is essentially a flare gun, signaling the autoimmune disease to expand its footprint precisely into the areas being traumatized.
Exactly.
The desperate attempt to soothe the symptom actively spreads the disease.
It does. And tragically, the scratching doesn't even provide lasting relief.
Of course not.
In fact, it amplifies the original symptom through what's called the itch-scratch-itch cycle. It is basically a localized chemical warfare happening right below the surface.
Let's look at the mechanics of that cycle, because your sources highlight the role of mast cells here.
Right.
Mast cells are part of the immune system, and they are absolutely packed with granules of histamine.
Right, and histamine is a highly potent inflammatory mediator.
Yeah.
When a patient violently scratches that fragile atrophic skin, the sheer physical shearing force actually traumatizes the mast cells resident in the tissue.
It breaks them open.
Yes, that mechanical trauma causes the mast cells to degranulate, essentially bursting open and dumping massive amounts of histamine directly into the interstitial space.
And since histamine binds directly to the itch receptors on the nerve endings, you're creating a massive feedback loop.
Exactly.
To scratch to relieve the itch, the physical force bursts the mast cells, the histamine floods the local nerves, and the itch signal shoots back to the brain with twice the intensity,
Right.
which demands even harder scratching.
It's a self-fueling fire. And this isn't a loop that happens, just once or twice.
No.
Because anogenital lichen sclerosus is frequently delayed in diagnosis, this aggressive itch-scratch-itch cycle can spin out of control for weeks, months, or even years.
That sounds agonizing.
It is. The tissue is subjected to a chronic daily barrage of friction and histamine.
Which really begs the question, what happens to that paper-thin, cellophane-like tissue when it has to survive that constant mechanical assault for a year?
Well, it undergoes a complete structural metamorphosis.
It has to, right?
Yeah. The original atrophic tissue simply cannot survive the constant friction. To defend itself against being entirely rubbed away, the skin fundamentally alters its architecture. It builds armor.
Your sources identify two distinct structural changes that define this armoring process. The first is hyperkeratosis.
Right.
We know keratin is the structural protein that makes up the outer layer of our skin, our hair, and our nails. So in response to the chronic trauma, the basal layer of the skin goes into overdrive, multiplying those keratinocytes rapidly to thicken the outer barrier.
It is a profound thickening. Clinically, a hyperkeratosis in this context presents as a whitish, sort of warty thickening of the skin.
Oh, wow.
Yeah, and you will often see prominent hair follicles that have become clogged with dry, hard plugs of excess keratin. The skin is desperately trying to build a thicker shield against the fingernails.
And that leads right into the second major structural change, which is lichenification.
Right.
This is where the skin becomes thick, coarse, and deeply leathery. If you look closely at normal, healthy skin, you can see a faint, microscopic grid of lines.
Sure.
But with lichenification, because the epidermis has become so unnaturally thick and hyperproliferative, those normal markings become deeply exaggerated. They form a highly visible, grooved crisscross pattern.
What's fascinating here is, well, the body hasn't just mutated the presentation of the lichen sclerosus.
Okay.
By building this hyperkeratotic, leathery shield, the body has actually layered a completely second disease state on top of the first.
Wait, really? So what does this all mean for the pathology of the tissue? Are we saying the patient now has two distinct conditions?
Yes, exactly. This new leathery change is clinically classified as lichen simplex chronicus, or LSC.
Okay.
It is the end-stage result of the chronic itch-scratch-itch cycle. Because the patient was trapped in that cycle by the primary lichen sclerosus, this thick, leathery LSC has now become superimposed directly over it.
That's incredible.
The clinical texts are very clear on this. You now have two distinct dermatological conditions occupying the exact same real estate.
It's brilliant, but, disastrous at the same time. It's like a guitar player who plays until their fingers bleed, and eventually The body reacts to that friction by building thick, hard calluses.
That's a great analogy.
Except here, the body's defense mechanism has completely masked the underlying disease. You have this tough, warty leather sitting directly on top of porcelain white tissue paper.
And that superimposition creates massive structural instability.
Also,
We have to remember that even though the top layer of the skin has built this formidable armor of lichen simplex chronicus, the underlying dermal architecture is still riddled with lichen sclerosus.
oh, right.
It remains inherently fragile, inelastic, and diseased.
Which brings us to the collateral damage. The metamorphosis isn't just about thickening. It's about the absolute destruction of the tissue's structural integrity. When a patient engages in that deep, desperate scratching, they are applying immense sheer force to a completely unstable foundation.
The clinical descriptions of this damage are really intense. Because that underlying tissue lacks the elasticity to absorb the mechanical stress, the blood vessels below the surface are easily sheared and ruptured by the scratching.
Ouch.
Yeah, the texts note that the tissue readily develops profound purpura and ecchymosis.
Basically, you are seeing massive blood pooling and deep purple bruising under the skin
Right.
because the connective tissue that normally supports those tiny blood vessels has been destroyed by the LS, and the friction just tears them wide open.
Exactly. The mechanical tearing also leaves visible tracks on the surface. Clinicians will observe excoriations, which are the linear scratch marks gouged deeply into the hyperkeratotic skin.
And perhaps most painfully, the tissue develops fissures.
Yes, fissures are a major issue here.
Let's talk about the mechanics of those fissures because it perfectly illustrates the paradox of this tissue.
Yeah.
Fissures are essentially deep, painful splits or lacerations, right?
Right.
But they happen specifically because of the structural mismatch we just talked about.
That's the exact mechanism. You have a thick, leathery, and flexible top layer of lichen simplex chronicus sitting right on top of an atrophic, fragile bottom layer of lichen sclerosus.
Okay.
When the skin is stretched, even through normal movement or during the act of scratching, the leathery top layer cannot stretch. It pulls hard against the fragile bottom layer, causing it to simply give way and split open.
It's like tectonic plates.
Yeah.
The rigid crust is snapping because the mantle beneath it is completely unstable.
That's exactly what it's like.
And these deep lacerations usually happen at the natural anatomical folds, right? Like the posterior fourchette.
do, yes.
You can also see broken hairs across the affected area where the constant aggressive rubbing has literally sheared the hair shafts off right at the surface of the skin.
And all of this trauma, all of this bleeding and hyperkeratosis, it completely alters the visual color profile of the tissue.
This is a huge shift. We established earlier that pristine lichen sclerosus is famously porcelain white.
Right.
But your sources emphasize that once the itch-scratch cycle has been raging, the constant inflammatory vasodilation and the pooling of blood completely destroy that original hue.
The visual presentation shifts drastically. The tissue morphs from that classic white to hyperpigmented shades of pink, or an angry, inflamed red, or a ruddy brown from the breakdown of old blood, or dark purple from the acute bruising. And in darker skin tones, the severe inflammation often presents as an intense, localized darkening of the area.
So let's sort of synthesize this for the listener, because the diagnostic implications here are staggering.
They really are.
A medical professional who examines a patient at this late stage is not walking into a pristine clinical picture. They are not looking at the classic white, thin, crinkly cellophane skin described in Chapter 1 of the textbook.
Not at all. They are looking at tissue that is deeply bruised, actively bleeding, covered in warty hyperkeratosis, deeply leathery and cross-hatched from lichenification, full of deep lacerations, and darkened to a red or purple hue.
It's totally different.
Yeah, it masquerades as a completely different pathology.
If a doctor just looks at that leathery surface, they might diagnose the lichen simplex chronicus and miss the underlying autoimmune lichen sclerosus entirely.
Which happens frequently.
And that matters because LS requires a highly specific, lifelong treatment protocol with ultra-potent topical corticosteroids to stop the architectural destruction. If you only treat the callus, the underlying fire just keeps burning.
If we connect this to the bigger picture, that misdiagnosis means the patient continues to suffer and the disease continues to progress, which can lead to severe, irreversible anatomical scarring.
That's terrible.
But the clinical texts in your sources highlight an even more tragic consequence of this visual metamorphosis, specifically when it occurs in pediatric patients.
This is an incredibly heavy but, crucial point to cover. because lichen sclerosus can present in prepubescent children,
Right.
and those children experience the exact same maddening pruritus, which means they engage in the exact same frantic scratching behavior.
They do. But consider what happens when a pediatrician or an emergency room physician examines a young child and observes these specific trauma-induced markers.
Okay.
They see anogenital tissue that is profoundly bruised with purpura, actively bleeding from deep fissures, and showing severe signs of mechanical trauma.
And without the context of the itch-scratch cycle acting on fragile tissue, those physical markers look identical to the physical signs of sexual abuse.
Tragically, they mimic it perfectly. The sources are very clear that the severe bruising and the tearing of the posterior fourchette caused by a child scratching atrophic skin can easily be mistaken for trauma inflicted by assault.
The psychological toll of that misdiagnosis is just unimaginable.
Completely.
A family brings a child in seeking relief for a skin condition, and because the mechanical trauma of scratching has completely disguised the underlying autoimmune disease, they are thrust into a devastating abuse investigation.
While the child's actual medical condition goes entirely untreated, it is the ultimate consequence of this biological paradox. It perfectly highlights why understanding the mechanics of this progression is so vital.
Right.
It is never just about memorizing a static list of symptoms. A clinician has to be able to look at the bruises, the leathery skin, and the fissures, and recognize them not as the primary disease, but as the collateral damage of human behavior acting on a hidden, fragile foundation.
To briefly recap this tissue's incredible journey for you,
Yeah.
we start with lichen sclerosus, an autoimmune condition that destroys the skin's underlying architecture, leaving it thin, white, and as fragile as cellophane.
Right.
But because it triggers an unbearable localized itch, it initiates a mechanical response, which is chronic scratching. That sheer physical friction triggers the Koebner phenomenon, recruiting more of the disease.
While simultaneously bursting mast cells to dump histamine, which amplifies the itch in a vicious cycle.
And to survive that daily mechanical assault, the body fundamentally alters the tissue. It mounts a defense by layering a second disease, lichen simplex chronicus, directly over the first.
Right. It turns the delicate white tissue paper into a thick, leathery, warty shield.
But because the underlying tissue remains fragile, the stress of scratching causes massive collateral damage. Deep purpura, broken hairs, painful fissures, and a total shift in color to angry reds and purples.
Which completely obscures the original clues.
Exactly. This deep dive proves why this knowledge is so valuable for you to hold on to. Recognizing a disease in the real world isn't about looking for pristine textbook examples.
No, it's not.
It's about understanding how a symptom, like a severe itch, forces an action that physically rewrites the evidence over time.
It requires looking past the thick defensive armor to recognize the vulnerable underlying pathology that started the fire in the first place.
Which leaves us with a final lingering idea for you to explore on your own.
Okay.
Think about the incredible irony of this specific biological process. The body's natural evolutionary defense mechanism against physical trauma is to thicken the skin, to build a callus to protect you from harm. But in the case of lichen sclerosus, that very attempt to heal and defend actually traps the patient in a secondary, equally agonizing disease of leathery, itching skin.
It's a tragic irony.
It leaves you wondering, when we look at the broader world of medicine, how many things we confidently classify as the static symptoms of an illness are actually just the physical scars of our own body's misguided attempts to save itself.